respected chairperson, teachers, co-speakers, and my dear friends. The topic for today's discussion is going to be continuous glucose monitoring in pregnancy. So, as rightly said by Dr. Morley sir, CGM has been an invaluable or inevitable tool in the management of diabetes. So, in this context, what I thought I would discuss today is that I will just give you an overview of diabetes and pregnancy, and let me discuss the importance of continuous glucose monitoring, what exactly it is, how exactly it differs from self-monitored blood glucose. Let's try to look at evidences of CGM in pregnancy. I'll just have two cases which will make you understand the importance of CGM. What do the guidelines say of use of CGM in pregnancy? And finally, I will conclude with a key takeaway message. So, diabetes in pregnancy, we know it could be pre-gestational and gestational. And gestational diabetes is glucose intolerance detected first time during pregnancy. So, which could be undiagnosed pre-gestational diabetes or new onset gestational diabetes, and it basically affects 16% of pregnancies in India. And as obesity increases, PCOS increases, the incidence of gestational diabetes also increases. So pre-existing diabetes, which could be pre-existing type 1 diabetes and pre-existing type 2 diabetes. The advantage with pre-existing type 1 diabetes is that patient is already on insulin, so you just have to see whether the control is good. The problem with pre-existing type 2 diabetes is that when the patient is planning for pregnancy, they should be able to change to insulin, and even if they change to insulin, as the insulin resistance increases in pregnancy, their blood sugar keeps on increasing, and dose titration is very, very important. So all types basically require a meticulous glucose monitoring to prevent adverse maternal and fetal outcome. But if you are able to control your blood sugar, you might be able to prevent various maternal and neonatal risks. So what are the common maternal risk factors in gestational diabetes? Maternal, there's increased risk for hypertension or PAH in pregnancy, increased risk of cesarean section or macrosomia, and postpartum hemorrhage increases, and the probability of mother developing future diabetes is also high, which is roughly around 50% within 5 to 10 years. You know, various data, some suggest 30% in 2 years, some suggest 30% in 3 years, but ultimately 50% will develop diabetes within 5 to 10 years. The fetal and neonatal risks, you can have fetal macrosomia, you can have neonatal hypoglycemia, you can have high rates of NICU admission, respiratory distress, hypocalcemia, hypomagnesemia, there's increased risk of stillbirth. Congenital anomalies, especially cardiac defects, are seen if the patients have pre-gestational diabetes. So I think it's a common multiple choice question which suggests whether you have congenital abnormality is present in GDM. Because the initial definition was that GDM happens only in late second trimester, which is roughly around 24 to 28 weeks. Nowadays, we have newer terminology, what is called early GDM, where your gestational diabetes is diagnosed much earlier. And in this scenario, your CGM is very, very useful. So whatever may be the reason for your hyperglycemia, if you are able to control your blood glucose, and your maternal and fetal risk could be reduced. And controlling blood glucose, as of now, gold standard is insulin, and insulin is the gold standard for managing gestational diabetes. But what we have to understand is any therapy you are being using, it has to be periodically monitored, and dose titration has to be done. So monitoring of blood glucose basically helps to guide your medication adjustment. It helps to identify the patterns, and it helps to bring to a clinical attention. It empowers patients' full self-management, and of course it prevents acute complications like hypoglycemia or severe hyperglycemia, which could require hospitalization. Now, how exactly do you monitor? We have laboratory blood glucose which could be monitored, but practically it is very difficult to frequently prick a pregnant mother or anyone just for sake of monitoring. So what commonly approved monitoring is this a self-monitoring of blood glucose, where you do a finger stick testing, and you have various glucometers which is available, and we know it may not be as accurate like a laboratory method, and there could be 10 to 15% variation, but still it is approved as a standard of care. So the another monitoring which has been commonly done in a routine diabetes patient is a hemoglobin A1C, HbA1c, which reflects 2 to 3 months average blood glucose. But in pregnancy, what happens? Your physiological changes in pregnancy increases your red blood cell turnover. So your HbA1c may not be the best marker in pregnancy. And again, HbA1c takes 3 months to change. Pregnancy itself is a very short duration, so you may not totally rely on your HbA1c, but of course we can use fructosamine, which reflects 2 weeks blood glucose in pregnancy. But what we are going to discuss today is the importance of a continuous glucose monitoring, how exactly it is going to be useful in patients with pregnancy for monitoring. So the traditional self-monitor blood glucose, what we have been using for decades, is that you do whenever you want to do it. So you can do it in a fasting state, you can do it in a pre-meal, you can do it 1 hour, 1.5 hours, 2 hours, whatever it is. It is consciously you are monitoring your blood glucose. There is nothing done subconsciously, your blood sugar is not at all monitored. Whenever you want to see, you do it. Maximum you can do is 7 to 8 painful pricks you can do it per day. More than that is very difficult. And the limitation of self-monitored blood glucose is that it provides only the snapshot of glucose levels at a testing time. And it misses nocturnal hypoglycemia, and it misses post-meal glucose peaks, and it cannot detect rapid fluctuations between the testing times. And there's a pain and inconvenience which leads to reduced adherence of your self-monitoring blood glucose. So in this context, continuous glucose monitoring represents a technological breakthrough in diabetes management, where it has an important tool in pregnancy to monitor your glucose control. The core feature of CGM is that there's a small sensor, you can see there's a small sensor which is inserted beneath the skin and which could be used in the arm, or sometimes you can use it in abdomen also, depending on what company sensor you have been using. It basically measures your interstitial blood glucose. You can measure your blood glucose in your blood, venous plasma, whatever it is. It measures your interstitial blood glucose. The methodology it uses is a glucose oxidase method, and it provides even your meter can provide alerts for a high glucose, low glucose. If you have insulin pump, it can get incorporated with insulin pump also. The sensor measures, as I said, the interstitial glucose, which lags behind the blood glucose by 5 to 15 minutes. There could be a slight lag, but again, it is basically uses the pattern. And the modern continuous glucose monitoring system can function for at least 7 to 14 days. And so, which is for 14 days, you can measure your blood glucose beautifully. And nowadays, your sensors are available where you can just scan with a Bluetooth to your mobile phone, or you can have your reader for doing it. As I said, the real difference between your SMBG and your conventional CGM is that this, you can see your self-monitored blood glucose, it's more or less normal. So I see the blood glucose in 4 times. On contrary, when I use a continuous glucose monitoring, it keeps monitoring totally. So my SMBG will miss this peak and will miss this trough of hypoglycemia. Now, even if I do a HbA1c or fructosamine, it is going to be normal because it is going to reflect your mean blood glucose. Sometimes we see many patients coming to us, GDM, sir, I have macrosomia, but the sugar is always normal. The gynecologist has told me to control the blood sugar. So we always try to do a blaming game. We tell there's nothing from the glucose, you go see a gynecologist. Gynecologist will say, they tell your diabetes doctor to do something, the fetus is growing fast. The problem happens is we really don't know what happens to a patient. I think this CGM will really give you a tool, when is your peak and when is your trough, how exactly it has to be monitored. So CGM advantage is that you can have more than 288 readings per day, where it records every 5 minutes. And again, this depends on whatever CGM you have been using. It captures full 24 hours glycemic profile. It detects patterns and trends over time, and it can also alert for a dangerous glucose level. So the types of continuous glucose monitoring: one, you have a CGM which is placed. You can have a reader where only when you use a reader, your value is seen. And again, you can have a real-time CGM where you can have your reader in your mobile phone, which you can scan it also. You can have an integrated CGM where if you are using an insulin pump, your CGM could integrate with your insulin pump. So you can have 3 types of CGM which is there. And of course, the cost varies between each thing. So if suppose you are using your different reader, your CGM cost would be roughly around 2,500 rupees. If you use your mobile phone to scan, your CGM cost is roughly around 5,500 rupees is the cost of CGM. Integrated CGM, of course, we should extrapolate the cost with the cost of the insulin pump also. So we cannot really go by the CGM cost alone. So it's as simple as that. So you can see this is the size of CGM. So application is very easy. They have their own applicator which is available. You just have to apply it with you can do it by yourself. You need not go to a hospital or doctor, and you can do it by yourself. And once when you apply, it is generally painless. You can see this is the needle length which is there, which is a microfilament, which is just a 4 millimeter, which is beneath your skin. Usually it is not painless. It is not painful. It's a painless. And once when you scan with your mobile phone, this is how your reading will look in your mobile phone. So it's very easy. You can scan even 10 times a day. You can scan 100 times a day. Depending on whatever you want, you can do it. And there are important things. What you can see is you can see a current glucose reading. And more important, you can see a trend value. It will show whether your glucose is showing an increasing trend, or whether your glucose is showing a static trend, or whether your glucose is showing a decreasing trend. So this is very useful because I see a blood sugar, suppose I see a blood sugar of 80 and it shows a decreasing trend, I am worried because this patient is going to end up with hypoglycemia. If I see a blood sugar of 80 and it shows an increasing trend, I am not at all bothered because the sugar is going to increase. If suppose I see a blood sugar of 200 and it shows a decreasing trend, I know it is going to come down. I need not immediately react. So this trend arrow is very, very useful. It indicates if glucose is going up, down, or changing slowly. And of course, you can have a glucose history where you can see how it has happened with each food. And you can also have a note where you can track the food, insulin use, exercise, everything could be done. And nowadays, this CGM, we can get incorporated. Suppose you have a patient who is on this CGM, you can get the same data incorporated in your mobile phone also. There is something called Libre Link Up. So whenever the patient scans for the sugar, you will be able to see in your mobile phone. Suppose I have at least 4 or 5 patients' data here. So whenever they scan the mobile, I might be able to see the blood values here. So the advantage here is especially in type 1 diabetes where your child is going to the school. So when the parents can tell the child to scan in the school. So in the interval when the child scans, blood sugar is 60, the parents can alert the teacher to have some eatables or something. So remotely you can monitor with this CGM. So it is very, very useful. So not only these data which is available in CGM, the another important data which are available in CGM is that you have what you call is that time in range. So time in range is nothing but how much percentage of day your blood glucose is within the range. So nowadays we don't go by fasting alone, we don't go by postprandial alone, we don't look at HbA1c alone, we look at time in range, where in routine type 1 diabetes, any diabetic patient, 70% of their blood sugar should be within the range. Less than 25% should be above the range and less than 5% should be below the range. In pregnancy or in GDM, usually at least 90% of the blood sugar should be within the range. So CGM and the use of time and range in combination with HbA1c should be the new standard of care for management of glucose, especially in those patients with GDM or diabetes complicating pregnancy. So we have various data which suggest you have UK randomized control trial which was, the number was small, which was done in 71 pregnant female with type 1 and type 2. What they showed was when you use a CGM compared to a self-monitored blood glucose, your HbA1c reduction was 0.6% greater. More important, your macrosomia reduction was 50% less compared to a CGM with SMBG. We have various other data in pregnancy also. We had concept trial where they said CGM use led to improved neonatal outcomes in terms of 53% reduction in neonatal intensive care admission, 35% reduction in neonatal hypoglycemia, 50% reduction in large for gestational age babies. We have data from glucomoms trial also, which basically suggests there was a reduction in large for gestational age infants. Flamingo study again compared CGM with SMBG in GDM patients. There were lower fetal macrosomia in patients who were using continuous glucose monitoring in pregnancy. I think this CGM will play an important role, especially when there's a disparity between your blood glucose and your fetal growth. I feel every mother should be suggested this continuous glucose monitoring. So the data, what you have from CGM, you are able to identify the pattern, whether it is increasing, decreasing, whether it is nocturnal hypoglycemia. You are able to validate the result and you are able to adjust the treatments. And many times you are able to refine the diet. You just tell when the patient taking 3 idli, you take 2 idli now and 1 idli later. You can just titrate with diet. Not every blood glucose value needs a titration of your medication. Many times diet alone might do a wonder. So this I will just show you a pre-gestational type 2 diabetic patient who is 46 days pregnant, 4 abortions. And you can see known case of hypothyroid and 100 microgram. Fasting is 106, postprandial is 262, HbA1c is 8.7. We know it is definitely not a good control, but many a times with 4 abortion, this thing, many a time parents, they want to continue the pregnancy and take a chance what is going to happen. It becomes a precious child. So this patient was put on Lispro insulin, 10 in the morning, 10 in the afternoon, and Lispro mix, which is 10 units in the night. You have various ways of insulin regimen. You can follow whatever regimen you are comfortable, you are confident with, but ultimately your blood glucose has to come under control without hypoglycemia. So this patient, routinely you monitor with a glucometer. You can see these are a value. Your target should be, when you are monitoring, 1 hour it should be less than 140, 2 hours it should be less than 120. So your fasting is more or less normal. Postprandial lunch is also more or less normal. I would say it's slightly low. And breakfast is normal, post dinner is high. And again, this patient complains of hypoglycemia after lunch. So naturally, you tend to decrease your lunch dose and increase your dinner dose. So that is what we tend to do it. And that is what was done for this patient also. You reduce your lunch insulin by 4 units and your dinner by increase by 4 units. But this patient was repeatedly asking whether what we did was right. So, and we said, well, why don't we do a CGM and see what has been happening. So this patient was done a CGM, and I will just show you what was the CGM reading. So this patient, as I said, post-lunch was, after the change in dose, now 10 units, 6 units, and night patient is taking 14 units. You can see there's lots of nocturnal hypoglycemia is there. And post-breakfast and post-lunch, again the blood glucose is high. Already this patient has a problem post-lunch where she had a hypoglycemia. So what we did for this patient is that we retained this dose of 6 units and we told them to split the lunch what the patient has been taking, so that this hyperglycemia, you split the breakfast, split the lunch. Since the patient had hypoglycemia at night and initial reading was hyperglycemia post-dinner. So we thought instead of Humalog mix 25, we'll change to Humalog mix 50, where 50% is going to be a short acting, 50% is going to be a long acting. The same patient is on CGM. The CGM is on 14 days. You can easily see whether it has worked for your patient also. So you can see after that the blood glucose are reasonably within the range, and you can see the time in range. So this is the time in range which is more than 70%. If it's more than 90%, your maternal fetal outcome is going to be the best what you can have for your patient. So this is another patient, have gestational diabetes mellitus, 8 weeks pregnant, fasting is 136, postprandial is 201. I would say whenever you have such a high blood glucose, your oral glucose tolerance may not be required for every patient. And your HbA1c is 5.7, which suggests it is not a pre-gestational. So it is only a gestational diabetes, because your pre-gestational HbA1c is high. So that is the real advantage of doing a first trimester HbA1c, which really helps you to decide whether it's a pre-gestational or gestational diabetes mellitus. So this patient was put on human actrapid 4 units in the morning, 4 afternoon, and mixed 4 units in the night. And we did a CGM. This is the CGM for this patient. Now you can see post-breakfast is high, post-lunch is also slightly high, post-dinner is also high. Now if I increase this 4 to 6, you can see pre-lunch patient is having hypoglycemia. Now when I increase this short acting to 6 units, this peak will be taken care, but this trough will also get worsened. So what we did is, these are kinds of patients which would best suit with analog insulin, where the onset of action is very fast and the duration of action is also slightly less. We just change the insulin to analog insulin, and you can see the CGM data. It is so beautifully maintained. Your time in range is also high. So these kinds of insight you will definitely get with your continuous glucose monitoring. You can have various data which is seen. And nowadays we have data to suggest doing continuous glucose monitoring in first trimester. Now, normal pregnancy, no GDM, you do continuous glucose monitoring first trimester. Your first trimester high blood glucose values predict your hyperglycemia, the chance of GDM in the second trimester. So with CGM, you might be even able to diagnose or predict your probability of pregnant female who will develop gestational diabetes mellitus. So professional guidelines, American Diabetes Association, CGM should be offered for all pregnant women with pre-existing diabetes. The same thing with International Association of Diabetes and Pregnancy, NICE guidelines. Indian guidelines suggest CGM should be considered standard of care in type 1 diabetes pregnancies where resources permit. RSSD again endorses the use of CGM in high-risk pregnancies and problematic hypoglycemia, and same thing has been endorsed with the gynec societies also. So integrating CGM in antenatal care, highest priority goes to all women with type 1 diabetes should be offered CGM. high priority pre-existing type 2 diabetes with poor control, selective users, GDM requiring insulin, history of hypoglycemia, unpredictable glucose patterns, mismatch between your fetal growth and your glucose what you see. Intermittent use, well-controlled GDM, pre-diabetes and risk factors. The implementation timeline you do as early as possible, either pre-conception, in pre-gestational diabetes. First trimester, second trimester, third trimester, you can consider using the CGM. And just to conclude, established benefits, you have strong evidence for improved outcome in type 1 diabetes, significant reduction in macrosomia and NICU admission, high patient satisfaction. Emerging opportunities, there's a growing evidence for benefits of GDM in type 2 diabetes. There's a potential for early intervention and prevention. Integrating GDM with artificial intelligence of our personalized care is very useful. And we have seen what are the types of diabetes in pregnancy. We have seen the importance of continuous glucose monitoring. We have seen various studies which support the use of continuous glucose monitoring. We have seen some case scenarios, and we have seen various guidelines which endorse the use of CGM and key takeaway message. And thank you so much for your